صباح الخير على الجميع. الوقت دلوقتي للسيشن اللي هي How I Manage Updates. May I call دكتور ريمون. Dr. Remon will talk about update in acute otitis media management.
Hey everyone, I'm really lucky here today to be with you, and I'm indebted to Professor Fatih Abdelbai for giving me the opportunity to be here with you in this mega conference in front of my really all the professors that I'm indebted to, including Dr. Yaoud Tureim, which was the head of the department when I was a resident, and I remember those days very well. So over the next 30 minutes or so, I'll be giving you a brief presentation on acute otitis media, a disorder which is very common, and everyone presenting to him with this patient with otitis media is managed in a slightly different way. So we are going to share our experiences and how do we manage acute otitis media, and I'm going to compare that to the available evidence in the literature. I have no disclosures to this declare, and I'm going to start my presentation with a vignette, and in a otherwise normal 3-year-old child with acute otitis media and fever 38.5 degrees Celsius and infrequent rubbing of the ear, I would routinely prescribe antibiotic, prescribe analgesic, prescribe pause, and observe the patient. Which one you would likely choose? In order to choose one of these, you can use your mobile phone and vote online. Just go to slide.com and enter the password. الباسورد مش باين. ممكن نصغر الشاشة شوية. Or you can scan this QR code and you get to that slide online and you can vote. Yes, so this is the website slido.com, and this is the password that you can use, and you'll get a screen like this. And so far we can see that 56%, like almost half of the audience, would prescribe post analgesic and antibiotic. Some of the audience, which is like 1/3, would prescribe just analgesic, and 10% will just observe the patient, 10% will just prescribe antibiotic. So the majority of the audience would prescribe post. Actually, the available evidence in the literature just favors the prescription of antibiotics and analgesics, and we are going to go through that over the next 30 minutes. As there is no clinical evidence, at least in the literature, supporting use of mucolytics, antihistamines, decongestants, and steroids. Let's start with the analgesics. It is straightforward. Pain in acute otitis media is at its peak during the first 24 hours and decreases after that. And it has been shown in several studies that acute otitis media without plus antibiotics won't relieve that pain unless the first 24 hours have passed. So analgesic has a strong recommendation by the American Academy of Pediatrics, and it should be prescribed whether you prescribe antibiotics or not. So that is the easy question. We'll shift to the difficult one, antibiotics. Should we prescribe antibiotics or not? And which antibiotic should we prescribe? So this is another question for you. You know, acute otitis media, I do not prescribe antibiotics except rarely. I try not to prescribe antibiotics, but I do commonly prescribe them. I try not to prescribe them, but I do often prescribe them. I always prescribe antibiotics. So we can see so far 75% are in favor of antibiotics, 25 do commonly prescribe them, while another 25% I don't see anyone not prescribing antibiotics so far. 7%. Well, so majority of the audience would prescribe antibiotics in almost every case. And there is some doctors that would not prescribe antibiotics, or at least try not to prescribe antibiotics, but they often prescribe them, or they do commonly prescribe them. At least this category will be the third of the audience will try not to prescribe antibiotics, and really half of the audience would prescribe for every patient. Everyone actually has a different policy, and all policies are correct. There's no right or wrong here. And we're going to compare that to the available evidence in the literature. So when you do prescribe antibiotics, you commonly use amoxicillin, amoxicillin clavulanic acid, cephalosporin, or macrolide. So we can see here like 95% of the audience is prescribing amoxicillin clavulanic acid. A small proportion would prescribe amoxicillin. A small proportion would prescribe cephalosporin. None of the audience would prescribe macrolide. Nearly 88% or 90% of the audience would prescribe amoxicillin clavulanic acid. The big caveat in management of otitis media in the studies that have shown the efficacy of antibiotics is that selection of the patients. So most of the studies, or many studies, do select patients and include them where they are having catarrhal otitis media and not acute suburethric. And obviously this undergoes spontaneous resolution. This is a very well randomized controlled study in which there were strict diagnostic criteria for the inclusion. The patient had to have middle ear effusion or evidence of effusion or pneumatic otoscopy, bulging tympanic membrane, and the marked erythema of the tympanic membrane or virulence behind the tympanic membrane to be included in the study. And this was conducted on patients aged 6 months to 2 years old, and it includes nearly 300 patients. And they were randomly divided into two groups. The first group was given amoxicillin clavulanic acid in a high dose, 90 milligram per kg for 10 days. And the other group was given a placebo, which looks and tastes exactly like the amoxicillin, and the bottle itself had the same labels of amoxicillin clavulanic acid. Both the parents and the doctors were blinded to this study. And these patients were followed up for 10 days, and they were advised to give them acetaminophen or paracetamol as needed to relieve the pain. They looked into symptom resolution at day 2, 4, and 7. At day 2, nearly 30% or 1/3 of the patients who took amoxicillin clavulanic acid had their symptoms resolved. And it's almost the same here. Amoxicillin clavulanic acid at day 4, 60% symptoms resolution, 54 with placebo. And at day 7, 80% with amoxicillin and 74% with placebo. And you can see that this is statistically insignificant. So it seems that giving amoxicillin clavulanic acid in a very well randomized controlled study have shown that really resolution of symptoms does not matter if you give amoxicillin or placebo, provided you are providing analgesia. However, there's another face of this reality. When they looked at the persistence of inflammation on otoscopic examination at day 5 and day 10, it was different. Only 4% had evidence of non-resolution of their symptoms at day 5 when they were given amoxicillin clavulanic acid. But nearly 1/4 of the patients had evidence of persistence of the inflammation. 16% at day 10, and nearly half of the patients at day 10 who had placebo didn't improve on otoscopic examination, and there was evidence of effusion. So one might raise a question: do antibiotics might be useful in preventing post-otitis media with effusion, right? Unfortunately, this study was not a long-term study that did not examine specifically this question, but you can extrapolate the answer from a Cochrane review, which was conducted in 2015, and it included several studies. And you can see here that it examined the presence of otitis media with effusion at day 2 to 4 weeks, 6 to 8 weeks, and 3 months. And you can see here that placebo was almost always comparable to the antibiotics. And the conclusion of this Cochrane review was that antibiotics does not improve post-otitic otitis media with effusion at 3 months. So the big question here, is it worth prescribing antibiotics if the antibiotics do not cause resolution of symptoms at a significantly higher rate than analgesia? Is it worth to prescribe antibiotics when acute otitis media with effusion would not, post-otitic acute otitis media with effusion would not be prevented by prescribing antibiotics? So this is a big question here, and I'm going to take your votes. Just give me 10 seconds. Really, there's no right or wrong answer here. If you go to the guidelines, you'll see that the guidelines are really more or less in favor of not prescribing antibiotics, but they do still recommend prescribing antibiotics. Again, if you remember the old days when the antibiotics were not that prevalent, we used to see a lot of patients having complications from acute otitis media, mastocytitis and extradural abscesses, which have been a rarity right now. So I believe that antibiotics do have a role in management of acute otitis media, but when to prescribe it and which patient should we choose, this is the dilemma that we are facing, and we have no clear answer right now. But we can extrapolate from the studies in the literature which patient should benefit from the antibiotics, just in case we are going to prescribe antibiotics. So you can vote right now. You can go to slide.com and enter this password, or you scan the QR code. Well, despite the evidence so far, we have seen that the most of the audience so far is prescribing antibiotics to every case, few cases. Well, it's nice to see this interaction. 40% will prescribe for most cases, 33% for all cases, and few cases, nearly 1/3 of the audience will prescribe for few cases, and no one with otitis media in 6%. So this is what I meant. Everyone has his own philosophy and his own way of treating acute otitis media, despite being a very common disorder, and there is no right or wrong here. You try to do the best for the welfare of the patient based on your clinical experience and what is available in the literature as best evidence. So you can see here, eventually, we have almost 1/3 of the patient, of the physicians will prescribe for all cases, nearly 1/3 will prescribe for most of the cases, and we can see nearly almost 1/3 or 1/4 of the patient of the doctors will prescribe it for a very few selected cases. But the majority will prescribe acute otitis media in all cases of otitis media, antibiotics for all cases of otitis media. So let's see what the guidelines recommend. I'm not going to go through the details of the guidelines because it's very perplexing, but guidelines have been published by the American Academy of Pediatrics, the American Family Physicians, Canadian Pediatric Society, and Italian Society of Pediatrics, and this is the most recent one. And the conclusion of all these guidelines is that antibiotics should be prescribed if the patient is less than 6 months. And this is agreed upon by most guidelines, the American Family Physicians and the Italian Pediatric Society. The other guidelines describe their guidelines based on patients 6 months and over. Severe symptoms, if the symptoms is severe, you should go and prescribe antibiotics straight away. And severity of the symptoms have been defined by pain for 2 days, severe pain, temperature more than 39 degrees. It is interesting to know that they did not consider the endoscopic findings of a bulging tympanic membrane with an impending perforation, which I would usually prescribe antibiotic to, regardless of the severity of the pain, because this can be controlled by analgesia. Temperature can be controlled by analgesia. Pain persisting for 2 days It usually persists for 2 days in 30% of the patients. But the most important point in my view is the bulging tympanic membrane with impending perforation, in which I will just go and prescribe antibiotic to avoid the fear of perforation. And bilaterality, it has been shown to have a benefit if the child is less than 2 years. Generally speaking, if acute otitis media is develops in a child which is less than 2 years, it is dangerous. It is more than 2 years, it is relatively less dangerous. So these are the guidelines, and they do recommend prescribing antibiotics for this selected group of patients. The next question, which antibiotic should I prescribe? Let's go straight forward and see what is the American Academy Guidelines of Pediatrics, and this was published in 2013. It was 2004 and was updated in 2013. And the see here, amoxicillin clavulanic acid, 90 milligram per kg is the first line. And if you are unable to prescribe amoxicillin for whatever reason, the alternative is amoxicillin clavulanic acid, which has been chosen by most of the doctors, cephalosporins, which are older, or ceftriaxone for 1 to 3 days. This guideline is really the most widespread guideline and most adopted strategy by most other guidelines. So most guidelines do still recommend in Italy, in Canada, in United States, amoxicillin at rate of the dose of 90 milligram per kg, even in 2022. There has to be a reason. This paper was published in 2022, 2 months ago, and it was a retrospective studies in which examined patients with acute otitis media that has been prescribed antibiotics, which was either amoxicillin, amoxiclav, cefdinir, or azithromycin, and it examines the combined clinical failure or recurrence. Clinical failure was defined by another antibiotic prescription within the first 2 weeks after the index antibiotic, and clinical recurrence was defined as an antibiotic being prescribed 15 days to 30 days after the index antibiotic. And you can see here that the failure or recurrence rate was almost comparable, 10% among all these antibiotics, and only 2% among amoxicillin. Obviously, this is a retrospective study that can be easily criticized because it might have happened that the simple cases were prescribed amoxicillin, difficult cases were prescribed amoxicillin, and this has that this discrepancy. But the conclusion of this paper that amoxicillin is still valid and it should be the first line treatment even in 2022. Probably this is the most important slide in the entire presentation. If you can understand this slide, it will be easier for you to choose antibiotic based on a targeted approach. The most common organisms causing otitis media is obviously pneumococci, Haemophilus influenza, and Bazak 40%, about 10 to 20%, and 10%. So actually the most common organism is pneumococci, constituting nearly 50% of the cases. And when you are choosing an antibiotic, you should consider the resistance. The mechanism of resistance is totally different. Moxidectin lactalis produces beta-lactamase in nearly 90 to 100% of the patients. Influenza, Haemophilus influenza produces beta-lactamase in nearly 20 to 50%. While pneumococci, in most of the cases, they do not produce beta-lactamase, except very rarely, nearly 5% with their multi-drug resistant strains. But the main mechanism of resistance is altered penicillin binding proteins, and penicillin binding proteins is a transmembrane enzyme, which is essential for rejuvenation of the cell wall of gram-positive bacteria. So gram-negative doesn't have a 6-cell wall, the gram-positive has a 6-cell wall that undergoes continuous rejuvenation, and if you block this rejuvenation, the cell wall gets old and exposes the osmotically fragile cell membrane and eventually it ruptures. That's why penicillins are bactericidal. So if you are going to add clavulanic acid to amoxicillin, it won't help in managing pneumococci, the most common organism causing acute otitis media. Let's go a little bit deeper. Moxidectin lactalis, it constitutes a very small proportion of acute otitis media, nearly 10%, and it produces beta-lactamase in 100%. So if you're having a patient having Moxidectin lactalis and you prescribe amoxicillin, it won't help. Still, you can achieve 75%. You can achieve 75% bacteriological control with amoxicillin, despite being insensitive to amoxicillin. Moxidectin lactalis is an uncommon organism relatively to other 2 organisms causing acute otitis media, and it is in the most cases self-limited. It is not a bacteria that causes complications. And if you go through the literature and you find complicated otitis media, It's very uncommon to find Moxella lecturalis, and just in case if you find Moxella lecturalis, it is likely that it is a confounding factor, because many of the cases of acute media is not caused by a single organism, by 2 or 3 organisms, and this has been proven in studies. But what you culture is the most virulent one. So when you're having Moxella lecturalis or Haemophilus influenza, you might culture Haemophilus influenza and or Moxella lecturalis or both. The bacteriological cure rate drops when you go up. Haemophilus influenza has a bacteriological cure rate spontaneously without antibiotic in 50%. And it further drops to 20% when it comes to pneumococci. So you can see here that your main target in managing otitis media should be targeted towards pneumococci firstly, and second to Haemophilus influenza. And if you look at pneumococci, which constitute 40% of otitis media, 90% are susceptible to amoxicillin clavulanic acid. Haemophilus influenza, which constitutes nearly 15% or 20% based on the studies, 70% are susceptible to amoxicillin 90 milligram per kg. So that's why, and that's the main reason for prescribing amoxicillin. It's cheap, it is effective, it's palatable, and it decreases the incidence of resistance. So that's why amoxicillin is recommended by most guidelines. When it comes to microbiology, there is a slight shift. Currently, a pneumococcal vaccine is being compulsory vaccination in Canada and United States, and it is being electively given to some patients here in Egypt. And this has shifted in the flora causing acute otitis media. Before the BV vaccination era, it was 40% caused by pneumococci. But if you look at the post-vaccination status in the United States, it has dropped down to 30%. And this bacteria, 30%, though they are pneumococci, they are non-virulent strains. So you could see that more unlikely that these 30% are not likely to cause complications. And Haemophilus influenza, which is a virulent bacteria, by the way, is causing 40%. And this has led to increase in the Moxella lecturalis, fortunately, to 20%. So I believe that the patient who had had vaccination from the history, and I always ask the patient if she has given her child this Prevnar vaccine, it's likely to be caused by Haemophilus influenza. And the mechanism of resistance by Haemophilus influenza is beta-lactamase production, and that should be considered while prescribing the antibiotic. Again, 20% will be Moxella lecturalis, which I shouldn't worry about. But if I'm going to prescribe beta-lactamase, it should cover again this 20%. This 30% is relatively low, and it's more than likely caused by non-virulent strain. This includes 13 virulent strains. So what about macrolides? I didn't see any of the audience prescribing macrolides, or a very small proportion, 6%. It's not recommended by the guidelines, American Academy guidelines, for one good reason. This is a 2010 meta-analysis that includes 10 randomized controlled studies, and macrolide was treated with 8 greater risk of treatment failure. Just for your knowledge, this is another meta-analysis which published in 2021, and the conclusion was that azithromycin is comparable. It's not equal. It's comparable to amoxicillin. And this was published from Ethiopia in Addis Ababa. And if you look in depth in the this study, you'll find that many papers that were included in this study that show that amoxicillin is equivalent to azithromycin. You can see here that the dose that they were using was 45 milligram per kg. Again, this is another study that have shown that azithromycin is equivalent to amoxicillin. Again, they were using a low dose amoxicillin. Obviously, this will not cover pneumococci, and this has skewed the results of the meta-analysis. So currently, the American Academy of Pediatrics indicate macrolides only in patients with severe documented allergy. And it states that unlike what was briefly thought that amoxicillin, if you have a penicillin allergy, you will have cross hypersensitivity to amoxicillin. This is not true. It is highly unlikely due to the difference in chemical structure. So what about oral cephalosporins? I'm going to go through this fast here. The oral cephalosporin pneumococcal susceptibility is completely different from Haemophilus influenza. So if you're going to prescribe a cephalosporin, you should consider what your patient is likely having: pneumococci or Haemophilus influenza. You can see here that cephalosporin are less effective than amoxicillin when it comes to pneumococci, and much more effective than amoxicillin when they are compared to Haemophilus influenza. So this should be one of your cephalosporin treatment strategy. The cephalosporin that is most commonly prescribed is cifidinir. And this is one of the star studies that has been promoted by the company. Cifidinir was as effective as high-dose amoxicillin in the intention to treat group, but somewhat less effective in per protocol analysis. And actually, this is the caveat of the study. Intention to treat group does not include patients that have been dropped out from the study. And this is what should be more plausible in comparing amoxicillin clavulanate. Actually, amoxicillin clavulanate is much more effective than cifidinir, and this has been proved by another study that was conducted later on, and the efficacy of amoxicillin clavulanate acid is higher than cifidinir. And this is another study comparing amoxicillin cifidinir to azithromycin, and it shows that they are comparable. Azithromycin obviously less effective than amoxicillin clavulanate acid. What about ceftriaxone? I'm sure that all of you are aware about the 1 or 3 days regimen, and this is the first star study that has proven that ceftriaxone given at a dose of 50 milligram is equivalent to amoxicillin and astonishingly 40 milligram. And this study was conducted in 1993 when that was the dose of amoxicillin before the emergence of pneumococcal strains that are resistant to amoxicillin, and both were effective in 90% of the patients. And conclusion was a single dose is as effective as 10 days of oral amoxicillin. And this has been FDA approved as a treatment regimen. This study has examined patients who have failed an initial antibiotic. Sympanosis was performed. Ceftriaxone was given for 3 days, and another sympanosis was performed. And it has shown that bacteriological cure rate was 95%, 100% of influenza, 92% of pneumococci. Comparing, this is another study that compared 1 day versus 3 days regimen of ceftriaxone, and again, it was the same study design. Bacterial eradication in penicillin-resistant pneumococci was achieved in day 1 regimen, 52%, 97% in 3 days. So obviously, 3-day regimen is much more effective and is currently one of the favored regimens in management of acquired media, but it should not be the first-line regimen, because if you fail the first line, but for whatever reason, you have lost a lot of weapons. So it is currently not recommended to be given as a first-line agent. It should be referred to as a second or third-line agent. This is a very nice study in which patients were randomly assigned to either immediate antibiotic treat group or delayed antibiotic group. In immediate antibiotic group, the patient was prescribed antibiotics straight away. The delayed antibiotic group, they were given the antibiotic and were counseled to take the antibiotic if the condition of the patient deteriorates. And this study showed that only 25% or 24%, 1/4 of the patients in the delayed antibiotic group use the antibiotics. And wait and see approach reduced antibiotic use by 76%. And actually, this is what I adopt in my management. So I usually, when I'm going to prescribe antibiotic, unless it's a severe impending perforation or severe bulging of the membrane, I do prescribe the antibiotics if there is no option that I can see the patient within the next 24 to 48 hours. For example, it is Wednesday and I'm going to close the clinic on Thursday and Friday. I prescribe the antibiotic and tell the patient if the condition deteriorates, just give the antibiotic. So the target antibiotic therapy should include the severity of inflammation, whether the membrane is bulging, moderately bulging, severely bulging with impending perforation in some cases. The feasibility of the follow-up, which is very important. If you find the patient that is unable to come to you within the next 48 hours, whatever reasons, he is coming from a tour, for example, he has a work assignment that he cannot leave and come to your clinic within the next 48 hours, this is very important to consider. And the age. Usually what is less than 6 months, usually it is dangerous, it's uneasy to follow up the patient, it is uneasy for the mother to detect the deterioration of the condition, it is advisable to prescribe antibiotics, and it's advised by most guidelines. More than 2 years, it is likely that the patient will be having a self-limited disease, the probability of complication is low, and I would be more inclined not to prescribe the antibiotics. Pneumococcal vaccination, this is an important item that I consider in my clinical practice. I'd ask the patient if they have been vaccinated against pneumococci or not, and this might guide me if I'm going to prescribe cephalosporin or not, prescribe amoxicillin or not. And the last thing that I would consider, the previous antibiotic during the last month. For example, if I have a patient that has been given cephalosporin during the last month, I know that cephalosporin will indicate Haemophilus influenza in most of the cases. And I'm left with a flora which is likely or more likely is pneumococcal. So if I'm going to have an otitis media, more than likely I'll be having a pneumococcal infection that will likely respond to amoxicillin. I don't need to add amoxicillin clavulanate acid. In contrast, if I'm going to have a patient that has been given amoxicillin, more than likely that pneumococci has been eradicated and the patient is having Haemophilus influenza, and it's advisable to prescribe either a cephalosporin or amoxicillin clavulanate acid. This concludes my presentation, and thank you very much for your. Thank you very much.
Thank you, Dr. Remon, for this nice presentation. We have time for two questions.